Standard drug dosing protocols are dangerous for patients with hepatic impairment. When liver function drops, drugs back up and accumulate, turning normal doses toxic. This checklist outlines the foundational rules of hepatic dose adjustment. First, establish a baseline score. Second, avoid hepatotoxic drugs and NSAIDs entirely. Third, reduce doses for any drug with high hepatic metabolism. Finally, always start low and titrate slow. Strict adherence to these 4 steps is the only way to prevent fatal drug-induced toxicities in compromised patients. This table details the Child-Pugh scoring system, the mandatory first step before writing any prescription. It evaluates 5 criteria: albumin, bilirubin, INR, ascites, and hepatic encephalopathy. Patients accumulate points, placing them into Class A, B, or C, dictating which medications their liver can safely process. Writing prescriptions without establishing this severity class exposes the patient to severe adverse events. This graphic highlights our first absolute hard stop. Deferasirox is strictly contraindicated in patients who reach Child-Pugh Class C due to severe hepatotoxicity. This diagram shows why NSAIDs, such as piroxicam, must be universally avoided in decompensated cirrhosis. They trigger gastrointestinal bleeding, induce hepatorenal syndrome, and actively worsen ascites. If a patient is on these drug classes, you must substitute them immediately to prevent accelerated systemic organ failure. When an oral drug is highly metabolized by the liver, a cirrhotic liver fails to clear it during the first pass. This drastically spikes the active drug's bioavailability in the bloodstream. This graphic demonstrates the required adjustment for sertraline. Because it relies heavily on hepatic clearance, its use in a Class C patient mandates a strict 50% dose reduction and close clinical monitoring. This illustration shows the pomecol for beta blockers. Highly metabolized drugs like metoprolol must be swapped for renally cleared alternatives, such as atenolol or bisoprolol. You must verify a drug's specific route of metabolism before prescribing it to this demographic. This comparison chart counters a common clinical misconception regarding pain management. Paracetamol is safer than NSAIDs in liver disease, provided the dose is strictly capped at 2 to 3 grams per day for no longer than 7 days. This balance scale clarifies the use of enoxaparin. In cirrhosis, an elevated INR indicates synthetic liver failure, not an actual bleeding risk. This allows for the cautious use of standard prophylactic dosing. This target guidance confirms that propranolol remains viable if kept at very low doses. The clinical goal is a heart rate of 55 to 60 beats per minute while maintaining a systolic pressure above 90. While clinical caution is required, evidence-based limits allow the safe use of traditionally feared medications. Returning to our key takeaways checklist, remember the essential directives. Always calculate the Child-Pugh baseline first, completely avoid NSAIDs, and utilize renally cleared drugs wherever possible. Systematic, protocol-driven adjustments, starting low, titrating slow, and constantly monitoring, are the required standards of care for management.